I'm Deidre Cruz. I'm the Deputy Director of our Center for Health Equity. I want to welcome you to our November Jam session, November 2024 Jam session. We are really excited about our speaker today, and we're going to take a moment to introduce her in our traditional way of sharing some fun facts. But even before we get to the fun facts about Dr. Venkataramani, I wanted to invite her to tell us about her music selection that we were all
Thank you so much. So I think when asked about my favorite genre or like general type of music, I did mention I love all types of music, but I really love listening to Indian and South Asian film and folk music. And this particular song is from a movie soundtrack, and it was sung actually and composed by A.R. Rahman, who won an Oscar for his song Jai Ho from Slumdog Millionaire. So if you remember that song, that's actually not his best song. His catalog is amazing, and so this is all the songs on this soundtrack are amazing, and this is one of them. And They'll Say means from the heart. So I thought if I speak from the heart today, I can start with the song that comes from the heart.
Lovely. Well, thank you for that choice. I think we all are enjoying it. So we're going to start with some fun facts. And so for those of you tuned in, please engage in the chat to see if you can come up with the answers here. So we're going to talk about Dr. Maya Venkataramani's very interesting sort of background. So one thing is that while I think many of us had pets when we were growing up as kids, she shared with us that she certainly loved dogs as a kid, but never actually had a dog. Did have a goldfish that she won at a school fair, but her only other pet was what? Please engage in the chat and tell us what you think her actual pet was that she had. A snake. That would be.
I hate snakes, Chinema.
Now someone who knows Maya pretty well may have guessed. There is the correct answer. It is among the answers that have come through. So so very good. So the correct answer, Dr. Maruther, got it. It's a hermit crab. You want to tell us about your pet hermit crab? I mostly want to know what their name was. That's what
his name was Hermie. Hermie. And honestly, I think actually my dad is logged in, so he is responsible for me getting this pet. I love dogs. I grew up really wanting one. I begged my parents for one, and multiple reasons it just wasn't possible. But I think when I was in middle school, I grew up in upstate New York. There was a fad for middle schoolers to have hermit crabs as pets. So we went to the pet store. We didn't tell my mom, and we came back with Hermie, the hermit crab. He lasted about 2 or 3 weeks at my home before I gave him off to a friend who I thought could take better care of him, because I would freak out whenever you're supposed to like put them in water every now and then and allow them to come out of the shell. And I am very scared of reptiles of all types. And so I don't know why I thought this was a good idea, but the first time I did that and he didn't go back in the shell, I just was kind of done with it. So yep, that was Hermie the hermit crab.
Wonderful. So
responsibility
in honor of Hermie. Yes, I love the compassionate adoption that you put Hermie up for.
Yeah.
That is great. That's right. I think this may be the first time we've had a jam session speaker's parent on, so that is awesome.
Yeah.
So you hope we'll get to hear from your dad. That's great. So another fun fact. So let's see, how should I ask this one? So Dr. Venkataramani enjoys artistic activities, particularly as a younger person. She enjoyed making crafts and painting and drawing, and she really was thinking when she was looking forward into her life, was thinking that she might be take on a field wherein she would get to use that artistic talent in the space of film. So do you all want to guess in the chat what type of role you wanted to play in the film industry that would make use of her artistic interests and talents? This is a smart group. Set design. I like that.
Mhm.
These are good. Okay. Well, the costume, dancing is good. All right. Well, once again, the correct answer did appear, and it was animation. Do you want to tell us about what you thought you might do in the animation space?
Yeah, I think so I love drawing and painting. I'm not very good at it, but I enjoy doing it. My mom and brother and dad are really good at it, but I didn't get that talent passed on. But I had watched, I think it was Hunchback of Notre Dame, the Disney version of it, and that was the first time I think Disney used a lot of computer animation in their film, and I was really taken by it, and I just thought it was awesome. And so I became very obsessed with Disney at the same time as also wanting to do that as a profession. It is so difficult. And as I said, I don't have a lot of talent in art, so I did not end up going down that route. But I think it would have been fun, and I wish I had a little bit more ability to maybe do what I wanted to do.
Very cool.
Mhm.
Well, that is neat. Well, the last fun fact that we'll share is that Dr. Venkataramani shares a birthday with someone that many of us, perhaps all of us, know at the Center for Health Equity. Do you want to guess whose birthday she's birthday twins with? Oh.
Mhm.
I love the fact that MLK is listed as
MLK.
the Center for Health Equity.
Yes. We're honored. Right.
Mhm.
Well, these are some great guesses. She is birthday twins with the great Dr. Lisa Cooper.
Mhm.
So, which is awesome.
Yeah.
So both of you, let's see, that makes zodiac sign is Pisces. Is it Pisces?
Aries.
Aries. And I
Mhm.
was like, I know
Yeah.
it's one of, yeah, it's in
Yeah.
that space. So Aries.
Yeah.
The center loves Aries. Yes.
She's a
Mhm.
good woman.
Oh.
Oh, so we were close.
Yeah.
For Dr. Golden, because that you
Mhm.
were
Yeah,
one of the guests here, so
yeah.
that's cool.
March 21st, on the
Oh,
first day of Aries.
wow. Oh, young.
Very cool.
Yeah.
And that's my mom's birthday. That's why I remember the 21st of March. That's why I
Mm.
remember the Aries, and it was kind of in that space. Well, wonderful. Well, thank you for playing all, and thank you, thank you for sharing your fun facts. So I want to go into a little bit more formal introduction of our speaker today. So we're delighted to have Dr. Maya Venkataramani with us, and she's an assistant professor of both medicine and pediatrics here at Hopkins, and she's a core faculty member at the Welsh Center for Prevention, Epidemiology, and Clinical Research, and also serves as Associate Director of Community Program Implementation for the Johns Hopkins Bronchitis Center, which is focused on the advancement of community care. After finishing med school at Hopkins, Dr. Venkataramani was a resident in a combined program of internal medicine and pediatrics at the Brigham and Women's Hospital and Boston Children's Hospital in that combined program, and then came back to Baltimore to Johns Hopkins to do a research fellowship in general and internal medicine. And I know a number of colleagues from GIM and perhaps even some of the program leadership are also tuned in today. Dr. Venkataramani serves as a primary care physician at a federally qualified health center, the East Baltimore Medical Center. And as we'll get to hear some about, her research and program development efforts have focused on multi-generational and community-based approaches to enhance the delivery of effective primary care and preventive services among populations that experience health disparities. Her work has been funded through a K-23 award from the National Institute for Diabetes, Digestive and Kidney Diseases, which we'll get to hear some about. And we're proud that a couple of years ago, she was awarded one of our pilot awards through our Mid-Atlantic Center for Cardiometabolic Health Equity, or MATCH, and actually was in our first class of pilot awardees. And so I'm certainly super proud of the work that she's been doing. So without further ado, I'd like to turn it over to you, Dr. Venkataramani.
Thank you so much. I really appreciate it. I'm going to just take 1 second to make sure I get this right, which is that I show you the right slide. So, okay, I think you're seeing my slides now.
Yes.
Okay,
looks great.
perfect.
Yep.
And I am going to make sure that I look at the camera, not the slides on the side. So first of all, thank you again. I really, really appreciate that very kind introduction, Dr. Cruz, and all of you for guessing and playing along. I don't think I'm that interesting, but you made it fun. So that was great. And I also want to just note that I am incredibly grateful for the opportunity to speak today. I felt really intimidated when I was preparing for this talk. I really didn't think I had anything useful or impactful to say. And one of the things that I realized, so when I added the word untapped to the title, it was really a reflection of how I felt about maybe, having not advanced this area, this concept, this set of ideas as much as I kind of have wanted to over time. And I reflected on that, but thought, well, here's the thing. There's no better place for me to be able to present these ideas than this jam session, because here I have the ability to, speak with a community of dynamic and passionate people who could not only provide feedback, but perhaps see some of these concepts and apply them to their own work to advance health equity. So that I'm really excited about. And I also think, just reflecting on where we are today, in terms of post our recent election in our country, is just, there's no better time to be able to speak about all of this and kind of just gather the energy of the community that we work with and individuals we serve, in terms of continuing on the work that may be harder to do, but we'll continue to do it. I would also like to say that please feel free to interrupt at any time. The way my screen is set up, I may not be able to see comments that clearly, but you can definitely, if questions or ideas or thoughts, I would love to be, just kind of go free flow with respect to that. And I hope to get through all my slides, but I'm keeping an eye on the time. And if I don't, that is totally okay. So again, feel free to interrupt. All right, so today what I hope to do is first quickly orient us all to multi-generational approaches. Like, what are they and why do I believe they're important? And then take us through case studies, and maybe I'll get to the last one, we'll see, in which I really hope to kind of highlight a health equity challenge and talk about how a multi-generational approach in that area could potentially help to alleviate some of the disparities that we see with respect to those specific areas or that specific health equity challenge. So I'll start off by talking about, the multi-generational approaches to health equity. Why and what are they? But I'll start off by reflecting on the fact that, as Dr. Cruz mentioned, I did my residency in medicine and pediatrics. And the way that residency works is you spend 3 months rotating through adult medicine rotations, and then you move on to pediatrics. I was constantly bouncing between different hospitals. But it really highlighted to me the fact that when we talk about healthcare, how we deliver health in this country, and then later on, I realized even how we conceptualize programs like preventive programs, policies, we often do so by really like separating generations, right? We think about adults in their own kind of bubble and children in their own bubble. And there are some really good reasons for this, clearly that why we need to do so. But at the same time, I think in structuring the way that we do things in this way, we are really missing out on some opportunities specifically to advance health equity. And so what I mean by multi-generational approaches, though, is kind of breaking down those silos in the way that we either provide care or design programs or design policies or evaluate the impacts of those policies. So this could look like extending or expanding services and interventions in order to impact health across generations, so not just adults or just children. But it could also be so that could be in primary care or public health, for example, but it also could be the way that we look at policies that are health related or not, and assess or anticipate the impact of those policies across generations, which helps in both designing better policies, but also in advocating for those policies that clearly have a beneficial impact and maybe a threat. And so that's what I mean by multi-generational approaches, but maybe there's others here who will think of different ways to kind of conceptualize that too. And then why use multi-generational approaches? So the answer to why, I think, is that I think it's a really effective way for us to be able to address health disparities and advance equity. And there's a few reasons for this. So first of all, when you think of the family or the household as a unit, individuals in that unit share risk factors, whether they're biological, behavioral, related to social positions, related to disadvantages that cross generations. And those are reasons for why to intervene upon family units or household units, for example, or to consider the policy impacts among all family members. So that's one reason, if you think about the family as a whole. And then if you think about adults, if you think of, in particular, younger adults who may more likely be the parents or direct guardians of children, we know in general that they are often less likely to seek regular primary or preventive care. This may be due to less opportunities to access care, due to things like differential insurance coverage compared to kids, for example. But if we look at providing services more holistically, then as I will talk about in several slides, we can leverage some of those touch points where the kids are getting care, right, to really reach these younger adults. The other thing is that when we think about all adults, we should recognize that there could be unique challenges for those adults who are caregivers of children, specifically with respect to things like lifestyle behaviors or care seeking. And if we don't basically address those in some of our programs or policies, we may not be actually, addressing those specific barriers for this group. And then for kids, I think the concept here is that we know for children, adult caregivers play a large role in children's healthcare utilization, how they access care, and their health behaviors. So that is reason to really engage family units, right, in many programs and services where we're trying to improve either kids' healthcare utilization or their health behaviors, or to consider how policies that affect adults are actually affecting the way that they're also seeking care or services for their kids. And I'll kind of illustrate these whys as I go through some of these case studies as well moving forward. So starting with case studies, I'll start with this concept of primary care and multi-generational approach in primary care, and specifically looking at pediatric touch points and how they can promote maternal health. And I will go back to just kind of putting this in context. So I was a resident when I kind of started thinking a little bit more about this. This is supposed to be me in my primary care clinic. I was seeing a newborn infant for a newborn visit. The baby was doing really well. And mom was sitting there and she didn't look like she was feeling well. So in pediatrics, we generally do ask moms at these initial visits how they're doing. Oftentimes those are focused on concepts such as maternal postpartum depression, or making sure they have the support to take care of this newborn, right? As they are transitioning to home from the hospital. But in this case, mom, she just didn't look like she was feeling well herself. And I asked her, and she was really reluctant, but then she mentioned that she had a headache since she left the hospital. So she wasn't feeling great. And then she noticed, she kind of lifted up her skirt and showed that her legs were swollen. And this was in the days after she was discharged home. So, I examined her and we checked her blood pressure. It was very high. And so we sent her to the labor and delivery. And she ended up being admitted to obstetrics, the obstetrics service. And she essentially there was being evaluated for atypical preeclampsia, and I think they had ruled that out, and they ended up having to call a medicine consult as well just to see, because they were concerned about how mom was doing, essentially. And so at the end of the day, she actually ended up doing fine and was discharged home, and the baby did well throughout this as well. But it really highlighted to me this almost like missed opportunity. If I hadn't asked and mom hadn't been forthcoming, I don't know that she would have gone anywhere else in those days following her discharge to be seen. And that is concerning, right? But it really also highlighted to me the fact that, well, I was able to ask. I was there and she brought her kid in. So that was great, right? And hopefully that did prevent her from being another unfortunate statistic in terms of maternal morbidity and mortality. So that is, that sets the stage for something I had been thinking about, which is, in general, how do we promote caregiver health in pediatric settings? But in this specific case, how would this work in terms of really addressing one of our significant public health priorities in this country, which is addressing the disparities in maternal and infant health. Now, I am not an expert in this, and I know in this session you've heard in the past from Dr. Ogunwole, Dr. Jeffers recently, and Dr. Bauer. So please go back to their sessions to learn more about the background, but I will just set the stage with just some basic information. So we all know that the U.S. is not doing well with respect to maternal and infant health. The U.S. has the highest maternal mortality rates amongst high-income countries. Infant mortality follows a similar path, and unfortunately, disparities are highest amongst racial and ethnic minority populations. Black women have 2.5 times higher mortality rates than their white counterparts, and that general pattern is reflected in infant mortality as well. Furthermore, morbidity is higher among racial and ethnic minority women. Black women are at high risk for severe maternal morbidity, and women from all racial and ethnic minorities also have higher rates of ICU admission, for example, during delivery, which is just another measure of severe morbidity. So this is the issue, right? We know this is happening, and this is something that a lot of people are working really hard to figure out how to address. And we also know that these disparities are driven by multiple factors. And so I want to acknowledge that, because I don't want to say that this one little thing I'm presenting is going to solve the issue. It's just one small part of what's going on. But among all these different factors, one issue that we do see is the issues and concerns around healthcare access and utilization of mothers, both during pregnancy but also in the postpartum period. And this postpartum period in particular is a really important point of care, an important point of focus as well. It's often referred now to as the 4th trimester. And this is a quote from Dr. Ogunwole's work that actually multiple other authors are on the call as well. But she really highlights the fact that this is a critical time for improving the health of mothers who have experienced medically complicated pregnancies. And in postpartum care, what generally we have seen prior to kind of this heightened focus on it was we would say, you have a visit with obstetrics about 6 weeks after your delivery, and then after that, transition over to primary care. Either you had one before or find a new doctor and follow up with them moving forward. I think with the recognition, of course, of the importance of this postpartum period and really following moms, especially those who have had pregnancy-related complications or medically complicated pregnancies, the American College of Obstetrics and Gynecology did start to focus a bit more on really that postpartum period. So they said actually by 3 weeks have an initial assessment in some form, and then by 12 weeks, but somewhere in that 4 to 12 week period, there should really be that comprehensive postpartum visit. And that's just for moms who have probably in general have had an uncomplicated pregnancy. But you can see if mothers have like hypertensive disorders of pregnancy, they're recommended to have a blood pressure check right within 3 to 10 days. And then if everything is fine after that, they still should see their PCP. In some cases, they even recommend seeing a specialist like a cardiologist 6 months after follow-up. And then say moms have gestational diabetes, they're supposed to get screened for diabetes within 12 weeks for type 2 diabetes, and then thereafter get at least annual screening through primary care, right? And because they're at higher risk for developing type 2 diabetes over time. So there's multiple visits. This postpartum period it's a very important time period, and there's multiple visits that could be required. But we know that these visits aren't happening, right? And there's so many reasons why, but, and again, these are just a few, but you can see that they are all over the board when we think about it. There's concerns about insurance coverage lapsing in the postpartum period, which actually, many states have now expanded that coverage to 12 months, which hopefully will help. But this point of churning off of insurance is one that has come up. Limited access to obstetric or primary care. But even when patients have access, they are encountering providers and healthcare teams who are discriminatory, who have implicit biases in the way that they're handling the care of women and not really providing the quality of care that all women deserve. There could be inadequate kind of handoffs between obstetrics and primary care. Sometimes patients are just not aware, or mothers are just not aware that they need to be seen. Like for, oh, I had gestational diabetes, I need to be seen again later on, right? And that's on us if we don't heighten the awareness. And then also challenges, like in the case of the mom that I saw as a resident, to attending maternal appointments in the postpartum period. You're taking care of a newborn. There's so many things going on at home. You're not prioritizing yourself to be there, right? So there's multiple reasons why these visits may not happen, and they're not happening. So we know that, and these numbers may be higher for certain subgroups as well, but in general, 40% of women don't have that postpartum visit. For women with gestational diabetes, up to a half don't get screening within the year for type 2 diabetes, the follow-up screening. Women with high blood pressure or hypertensive disorders, nearly 4 in 10 do not follow up within that 6-month period to have their blood pressure checked, right? And so that is a health equity challenge that I present. And then thinking about now, okay, so how do we address this with a multi-generational view? So I'll go back to the mom I saw in residency. She may not have gone to any of these visits, right? In that time frame, I'm not sure, but I saw her probably within 3 or so days of delivery. But she did come for her child. She came to a pediatric setting because she was going to bring her kid in, right? And if you see here, there's so many, in the pediatric setting, we have multiple touch points with kids throughout this time frame, especially in the first 2 years. And these are just like the general recommended ones. Kids may come more often if there are issues that need to be followed up on, especially in those first few months. And this seems like, they're coming, and oftentimes these touch points, they overlap with time periods where mom is going to need something or almost need something. And so it seems like it would be a great way to really kind of figure out, how do you support mom to get the care she needs in that setting? And you might say, well, Maya, I've been to accompanied a family member to a visit. They don't talk about me. And why would we expect in pediatrics for like this to happen, right? Well, here's the thing. As I mentioned before, during my pediatric visit, I would have probably asked mom some things anyway. And that's because there is precedence in pediatrics to focus on the caregiver, right? In those areas in which we know it impacts child health. So Bright Futures lays out some guidelines in general for what pediatricians should be doing during these well child visits. And some of the maternal or caregiver issues that they recommend that we address include things like postpartum depression screening, tobacco use, intimate partner violence exposure, talking about family planning and preconception care, and even things like immunization. In this case, Tdap, because the AP there stands for pertussis or whooping cough, and we really want to protect kids from that. So we want to make sure the adults around them are immunized, right? So this does happen. At least there is precedent for some, focus on the caregiver health at these visits. And early on in my fellowship, I wanted to kind of understand, like, what in totality are people doing with respect to these? And so we did a survey, a national survey of pediatric primary care clinicians. And we asked them, this could be pediatricians, med peds, or family medicine providers, how frequently or whether or not they basically address some of these issues at least 25% of well child visits. And you can see that the vast majority of these pediatricians or pediatric providers were doing so, especially for these issues that are generally part of, what we do in pediatrics, right? But you can also see that there's some issues like family planning that is not as common. So at least there is a precedent for something to happen. Now the question is, what could happen? And I think I have to say that a lot of times, and I'll show a slide later on, this is really focused on screening, but the management part is different. And in my case, when I saw this mother, I'm also an internist, so I felt comfortable to get her blood pressure and figure out what to do. But it wouldn't necessarily be the case that if you weren't taking care of adults otherwise, that you may feel comfortable doing much more than some of the basic kind of steps. That being said, I think there definitely have been pilot studies that have shown proof of concept, and I'll show one here. And I want to actually thank Ananya Devan, who's a second-year medical student here at Hopkins. I met her recently. She's interested in obstetrics and gynecology, and she's also very interested in this concept. So she is going to be the future of taking this forward. But she actually showed me this paper, and this paper that describes one way that these touch points are being used to really advance maternal health. And in this particular case, this was work that was done through a QI project at the University of Texas Health Sciences Center in Houston. And what they did is they enrolled birth mothers of children less than 2 months of age attending a pediatric primary care practice. And they basically analyzed this as pre-intervention cohort and post-intervention cohort. And what they were trying to do in this is basically their protocol was that 2 days, 2 weeks, and 2 months, when the mom brings the baby in for a well child visit, a trained medical assistant in the clinic will take mom's blood pressure and also ask off a checklist about symptoms of potential preeclampsia. And then there's actually a management algorithm that was followed based on blood pressure and symptoms. And the next steps are either mom could be referred to the obstetrics ED or counseled on where to go next to, in what time frame to see their obstetrics provider or primary care for follow-up. What they found in doing this is that overall, over all these and over 1,000 moms that they looked at, 42 ended up having to go to the hospital. But the post-intervention cohort had the higher rate of moms actually being readmitted due to postpartum preeclampsia. And those moms in the post-intervention cohort, when they went earlier. They were their readmission was within 7 days versus 10. And they took this to actually say that, hey, we are able to screen and reach moms who really probably needed to go to the emergency room or to labor and delivery or OBED by catching them at these visits. And we're doing it in a way that they actually go in earlier and hopefully can mitigate any adverse consequences of the blood pressures the high blood pressure or the symptoms that they're having. So this was really neat, and when to see as a proof of concept, right? Because it expands what we're already doing in primary care. But the description of the intervention actually doesn't really clearly say who was doing it. And what I wonder, and I would say, is the challenge in kind of advancing this particular process is honestly, how do you ensure that this can happen in pediatric clinics, that people feel comfortable doing it, and really it's a sustainable intervention. And the reason I say that is actually based again on the work that we had done years ago when we'd asked these providers about the things that they do in pediatric primary care. They mentioned lack of time, lack of referral resources, and complex referral mechanisms, all things that really prevented them from being able to do the maternal or caregiver health promotion consistently. But also they talked about liability concerns and perceptions about what they are responsible for as pediatricians, and as preventing them from being able to do much more than what they normally do. And what they normally do, as you can see here, is primarily screening. And again, these are for these for things such as maternal depression or tobacco use. But things such as referral or medical management are not common, and it's not something that many will do. So taking it the next step is very difficult. And you can imagine could be a barrier in terms of introducing some other intervention to capture mom right in this setting. And we also asked, I called this the pushing the envelope question, but I asked, how would you feel, or how strongly do you agree or disagree that you as a pediatrician should do some of these things? And I asked here, if you can see here, screening adult caregivers for a chronic condition. So that includes things like high blood pressure, and it could include kind of what that study in Texas described that they were doing. And the vast majority of folks represented here in orange really disagreed or strongly disagreed as pediatric providers that they should be or would be able to do this comfortably. And it makes a lot of sense. There's a lot of, as I said, time, scope of practice, liability. There's a lot that plays in here. So those are, I think, the challenges in terms of taking this beyond pilots, et cetera, to really understand how you can make it happen, especially in busy pediatric primary care practices, including in like FQHCs such as mine at East Baltimore Medical Center, where the pediatrician has a lot to do for the kid to begin with. But I think even with those barriers, there are things that we can think about doing that people have tried to already bring into play to see if we can really realize the potential of these pediatric touch points. And one of them is co-locating services or team members in pediatric settings. So for example, an idea that one of my mentors, Tina Chang, who is a pediatrician, who really was kind of like a pioneer in this area, had looked at was with respect to if you wanted to introduce family planning services for adults in these settings, maybe you have a family planning nurse practitioner who knows and is comfortable taking care of adults on site, right? So that's one concept, but it's hard to get funding for that and to really kind of integrate that into an active primary care practice at times. The other way that people have addressed this, though, is looking at what's known as dyadic care models. So these are essentially clinics where you can co-schedule clinic visits. And these visits would be, so basically mom has her postpartum visit and the same day the newborn visit. And she can come in and see a primary care provider when she brings her newborn in as well. These are examples from colleagues, MedPeds colleagues of mine who have started clinics in Illinois and Ohio. And in both cases, again, though, they're really based in MedPeds clinical environments. So I think that can highlight to you kind of the challenge probably in doing this in places that don't have clinics like that, where you really have to kind of figure out how to co-locate all these providers and essentially create a new clinical kind of model to provide this type of dyadic care. But maybe that's the way we move in the future as well. And then I think one other way to think about it is levering other pediatric touch points. So what I mean to say is that there are other places that provide services to moms and kids, and they may be able to also be used as sites where you can initiate screening, enhance awareness, for example, or check in and make sure mom has appointments and so on. So there's multiple things that can be done there. We actually took a look at WIC. So WIC is the Special Supplemental Nutrition Program for Women, Infants, and Children. And the neat thing about WIC is they also have they provide services to pregnant women. So the WIC staff are comfortable in handling and guiding pregnant women throughout pregnancy and in the immediate postpartum period. And what we did here is we just looked to see among 18 to 45-year-olds in a national survey who have gestational diabetes, we found that about 20% of those women access WIC. And among those women who access WIC, up to 1 in 3 basically had not had any diabetes screening that they reported in up to the 3 years after they had delivered their last infant. So it shows you kind of like, it could be that up to 1 in 3 women that are seen at a site actually need a service. And places like WIC, for example, they do point of care screening for kids for things like anemia. So maybe you could expand what they're doing to think about reaching moms for getting that first gestational diabetes screening, for example. So that's potentially another way to leverage these touch points. And then I will just add here that your ideas are needed because, as I mentioned, there's a lot of potential for this, but I think in the multiple studies and examples that we have seen, the challenges in really integrating and getting this done in a pediatric setting they're many. And so it's really important to kind of understand how we can, use these sites and to what extent can we use them, but also use them consistently for this type of care. I will just quickly pause to see if anyone has any thoughts before I move on, but that was end of case study 1.
Maya, I was going to
Yeah.
say that somebody else has their hand up too. Mine will be quick. One thought that occurred to me was child care centers as places that you frequently find young children and parents as being a place for intervention work. So
Yeah, absolutely.
thought I had. And sorry I jumped ahead of you. So
No
so
worries. Thanks, Maya. Maya, you're talking about the primary care setting, and then having pediatricians over there. Are there any considerations in this model to also train the primary care provider themselves to focus both on the mother and the newborn in case where folks don't have access to pediatric services or even for well baby checkups. So I wonder if that's also somewhere being looked into, or the examples that you'd shown from Illinois and Ohio might be considering some of those models as well. Thank you.
Yeah, thank you, Nick. But I think that if I understand what you said correctly, I think the issue there will be the provider has to be someone who is able in their scope of practice actually have been trained in taking care, right, of the kid and the adult. And so that would be either a family medicine practitioner usually or a med peds provider, are usually the folks who have that certification to be able to do both. So I think expanding the number, I love MedPeds folks, expanding the number of MedPed folks or thinking about family medicine as another option is one way to highlight that. But that would be the main thing, is that there's always that scope of practice concern and what have you actually been trained to do, and it's specific types of providers who will be able to do that as well.
Mhm.
Thank you.
Dr. Ebe?
Hi, this is such a fascinating presentation so far, and I'm taking copious notes because I've never really heard anyone articulate the value of multi-generational care the way that you have, so thank you. One question I have for you, and I'd be happy to share this, you might already be familiar with this actually, is Dr. Tumaini Coker, who is at the University of Washington in Seattle, she and her colleagues put together kind of like an intervention package for well child visits. It doesn't incorporate what you're discussing, but they do include community health workers as the intervention modality for improving adherence, so to speak, to or receipt of well child visits. Do you think that that kind of, support could be something that could be of value in like a multi-generational, health approach?
Absolutely, Dr. Eby, and I think we've discussed this too with the work that you've done as well. But again, as you mentioned, so it's community health workers, CHWs, if they are able to support mothers in the challenge of actually making sure they have appointments and being able to get to the primary care appointments, or also enhancing awareness of why it's important to go, right? Because as we said, we don't do a great job of letting mom know you really do need to get your blood pressure checked in a few days, right? Or you need to get your repeat diabetes screening. I think that would be very helpful because clearly this is, as I said, multifactorial. There's so many parts to this. And that is one aspect of improving the postpartum care kind of continuum, is enhancing the way we help moms get kind of connected to care. So absolutely.
Yeah, thank you.
Mm-hmm.
Keisha Lockhart?
Hello, my name's Keisha Lockhart. So exactly what this is a great conversation, and I am a pediatric nurse practitioner and I'm also a certified nurse midwife.
Mm-hmm.
And so I have my own practice in South Carolina, and I combine those two. So when I'm seeing moms for all the baby visits, I'm also running through the whole bubble depth stuff that we talk about in midwifery world. I have my blood pressure cuff with me. And funny enough, your story happened to me 2 weeks ago. I had a mom who was about 5 days out, and she texted me because she couldn't get her OB. She couldn't get her midwife who was doing her prenatal care. And I work primarily in the capacity of a pediatric person, but I do some early postpartum care for the first 6 weeks for moms. And I go into their house and I'm able to sit and stay and talk and do an assessment that way. And mom ended up having preeclampsia. She had it before the delivery. And then in those next few days, her blood pressure was through the roof. And what you said about them going to the hospital and the ball being dropped. So I had to kind of talk her through the emergency room because they weren't taking what she said as what it is. And they were questioning her and everything. And I said, you know what, if I had my car, I would come and get you and take you to the other hospital. But that hospital she went to didn't even have labor and delivery. So they didn't even know a whole lot except your blood pressure is really high. And they did end up transferring her, but it was me texting her and saying, this is what you need to say, A, B, C, D, E, F, G, so that they could get her out and get her transferred to the care she needed. And she was direct admitted to labor and delivery again and started on MAG again, and she did well. But I was also saying, ask them for a hospital grade pump because you're breastfeeding now, and let's make sure these medicines they're putting you on, make sure they know you're breastfeeding. It's a lot, but since I have my own practice, I'm not affiliated with any system, so I can kind of do whatever I want. And so I have a direct primary care structure, so that allows me to do way more things than I would if I was bound by time, which I have been bound by time in my previous provider life. But this is an awesome way to deal with that, because we see them so often in primary care, especially the newborns, right through that first year. That this is, if healthcare can figure out a way to integrate this model in, it would be so helpful.
Thank you, Keisha. Thank you for sharing your patient story, because I think that highlights all the concepts that I kind of breezed through at the beginning, but like my colleagues like Dr. Ogunwole have really kind of enunciated and clarified as to why this is happening. And it sounds like we need more of you, so maybe that would help as well. But
Dr.
Dr.
Golden.
Golden.
Yeah, no, that's an excellent, excellent talk. And one thought I had, it definitely needs to be co-location of care. And like the other area where a lot of women postpartum don't have adequate follow-up is if they had gestational diabetes. It's recommended that 6 weeks postpartum that they get an oral glucose tolerance test to see whether or not they've returned a normal glucose tolerance, still have glucose intolerance, still have diabetes, because it has treatment implications for behavioral change, as well as, potential, like pharmacologic treatment interventions. So, I mean, that would be kind of like the blood pressure and the blood glucose are like two things postpartum that really need to be followed up. And I know probably it's been over 15 years ago now. There was an EPC report that Wanda Nicholson and Wendy Post led, and it was looking at, gestational diabetes. And one of the things that we talked about was it possible for that screening to be done at the pediatric follow-up visit? Because, most women are going to bring the baby in, but they may not get their care. So in terms of thinking about, it's a matter of getting like the blood pressure checked, like you were mentioning, but then another is considering like redoing that diabetes screening for women who had gestational diabetes.
Yeah, absolutely. That's an excellent point. And it's that you were pioneers in thinking about it 15 years ago. And so I think that's the amazing part, right? Like it's, as I mentioned, this is not something I came up with or a new concept, but it is something that I think has been out there. And I really just want more people to be aware of it, because if the more you know, the more maybe that we can advance that particular area. But thank you for all those ideas, and you should keep them coming, because clearly we have a lot of work to do here. And I will move on, if that's okay, to the next case study. And I think I will focus on this and spend time on it. It is okay if we don't get to the last one. I think this one is particularly relevant today, just in a time when we're very concerned about how policies are going to change in the coming months and years. And I hope this specifically case study just helps us kind of gives us hope and an example of ways in which we can evaluate and conceptualize impacts of policy, so that we can continue to advocate for those policies that really help the most vulnerable amongst us. So I'll move on to that, if that's okay. And this will be on evaluating spillover impacts. So I want to start off by introducing, so I'm going to speak specifically in this case about immigration policy to start, also relevant to the national discussion at this time. And I want to start off by introducing a concept related to immigration policy that advocates for immigrants and people who are immigrants and people who care for immigrants will be watching closely in the coming days. And this is called the chilling effect. And many of you may be aware of this phenomenon. So the chilling effect basically refers to how unfavorable immigration policies, or even rhetoric, but policies basically that may enhance the risk of deportation, or enhance the risk of individuals being deemed a public charge, which is basically a designation which makes it more difficult for individuals to obtain legal permanent residence, and can be based on the social services that you access or family members access, or policies that also may change individuals' perceived or actual lack of eligibility for certain programs, interact with that individual's immigration status to essentially impact how immigrants utilize healthcare and social services. In this case, in the chilling effect, you will have a decreased utilization of healthcare and social services. And ultimately, this will have an adverse impact on physical, mental health, socioeconomic status, and so on. And you can see here when we talk about this chilling effect, this is looking at that individual's or immigration status. But in all reality, that chilling effect is actually not just acting on an individual, it's really the status of the family, right? The household, and of all the individuals in the household that plays a role. That is the documentation status of a household member who may not have who may be undocumented can actually impact the care of others in the household and how they choose to receive care. And these households are known as mixed status families, and over nearly 17 million people in the United States live in a mixed status family, right? So there's a lot of folks who can be impacted beyond the individual when we have this adverse rhetoric. And in particular, when these policies impact adults in a household, there will be spillover on children. So that's where this multi-generational kind of lens comes. Here is something that actually is from 6.5 years ago, this article, but still relevant today. And this is about a mom named Marlene, and she basically was describing that she has a son who has special needs. He himself is a citizen. He is eligible for Medicaid and other services, but she is worried about accessing those and actually did not sign him up for certain services such as SNAP benefits because of her documentation status and her concern about being exposed when she goes to apply for those services and potentially being at risk for deportation. And this is heartbreaking to read, but it is also, it's not just in the press. We've heard it locally as well, and in the families we care for at our clinic. And I think the key here, the thing that I want to highlight is Marlene's son is one of 5.5 million children in this country who live in mixed status families. And these children are particularly vulnerable for having poor health outcomes due to various risk factors, including the fact that the vast majority live in families which live in poverty. And these kids are the very kids who would stand to benefit from critical public health services and social benefits, but they are at risk for not receiving them at baseline and also in settings where something like the chilling effect is in place. So this is the health equity challenge here. How do we promote uptake of services amongst this group? In general, as I said, at baseline, they often are not receiving services that they are eligible for. And so I wanted to make a positive spin out of this and say that if we look at policy levers to do this, policy levers that will help these kids get the benefits that they are eligible for and that they will benefit from, what if we think about flipping the chilling effect, right? Clearly, they're unfavorable policies. We know, and there's been multiple studies have shown that they decrease utilization of services. But what about favorable policies? Those that decrease the risk of deportation, decrease the risk of becoming a public charge, or enhance your eligibility for programs. Do these policies, regardless of immigration status, or in concert with them, do they actually, are they one way we can really promote uptake of the healthcare and social services for these families and these children and have a positive impact, right, on health and socioeconomic status? So the thing is, as I mentioned, there have been a lot of studies and a lot of data that showed the chilling effect is a real phenomenon and that it occurs. And there, I guess, because maybe we haven't had as many favorable immigration policies, there was less around the warming effect or understanding that until kind of fairly recently. And that's because we took a closer look at one of those favorable policies, which you may have heard of, called DACA, or the Deferred Action for Childhood Arrivals. So DACA was introduced in June of 2012, and it was introduced as a executive branch memorandum under the Obama administration. And what it essentially allowed is that it really targeted individuals who are called dreamers. These are the young, undocumented adults who are largely raised in the US. They've been here for a very long time. And it enabled them to be protected from deportation, essentially by giving you a temporary deferral of risk of deportation for a 2-year period, and also providing them work authorization so they could continue to study and then contribute to the workforce. And you have probably heard of DACA in the news recently because there had been multiple challenges to this memorandum. In 2021, there was an injunction by a district court in Texas, which halted the program. But what it basically halted was taking new applications in. But of the 500,000 Dreamers that are in the US today, they are able to still renew their application at this time. So fingers crossed. So there's still individuals who are being protected by DACA at this time. So since DACA's inception, there were several studies that examined the favorable effect it had on health And so there's several studies, and these are just a few of them here. And all of these studies looked at the DACA recipient, the dreamer, that adult, right? They looked at what happened to their health, their mental health, their access to care, their use of health services. And so that's great. And they often showed multiple benefits to this population. But then there is this one study that you can see here that was done, and it happened to be one of the study members happened to be my older brother. And so when I saw that he had worked on this, I said to him, "Hey, Athene, this is great." And he's an internist, right? So he was focused on adults, looking at what DACA does for his patients, his adult patients. And I said, "This is great. Can we look at how this potentially could impact the children?" Because I'm reading stories about women like Marlene and her son, and I'm hearing stories in my clinic about parents who are not seeking services for their kids. And I think it would be cool to see if this is a policy lever that actually helps children as well. So we talked about it a bit, and we thought, okay, why don't we do this? We'll take a look at whether maternal DACA eligibility can impact children's participation in WIC. So WIC, again, the Special Supplemental Nutrition Program for Women's, Infant, and Children. The reason we chose this program is multifold. One is that it's an important public health nutrition benefit program that has proven benefits for kids. The second is it's after about age 2, so kids up to 5 years of age are eligible for it, but there's a big drop off in the number of kids who access WIC even when eligible. So clearly there is room for improvement in enhancing kids' uptake of this beneficial program. And then also we know that in prior studies, although for WIC, your immigration status has nothing to do with your eligibility for WIC, you need not be a citizen to receive WIC benefits. WIC utilization is actually still impacted by the chilling effect. So we know that immigration status does play a role in uptake. So then we thought, well, let's see if there is a warming effect with DACA. I'm not gonna, I think in the interest of time, I'm just presenting what we did here, but I'm not gonna go through this in detail. The reason I put this out here is just to highlight that we did a difference in difference analysis to look at this. But the main thing I wanted to highlight here is in red. So we used the National Health Interview Survey to look at this. And the key here is that in order to do any of these kind of spillover impacts when you're looking at parents and kids, you have to have a data set that helps you actually look at the parent and the kid and link them. And so many of these national data sets do enable you to do that, which is really helpful. I wish they would make it a little bit easier to do. And so I only bring that up to say that if you are ever in charge of a national interview survey or are planning prospective collection of data on policies or other interventions that you're doing, please think about the other household members and the kids and kind of proactively think about how we can get this information. But lucky for us, they did have information on kids in here. And essentially what we did is we looked at citizen children less than 5 years of age, and we restricted our sample to look at citizen children who had moms who basically were 19 years and older, who were not citizens, only because we do not know documentation status for good reason through these surveys, but nearly 60% of people who report that they're not citizens on an interview survey are likely undocumented, so we focused on that group. Hispanic individuals, because the majority of DACA recipients at that time were of Hispanic ethnicity, and then we fixed like 2 of the DACA eligibility criteria, and by doing that, we were able to define our exposure, having a DACA eligible mom, as that mom being less than 16 years at immigration to the US and less than 32 years at the time that the DACA policy started. So that enabled us that's the exposure, right? And then our outcome is actually like the household member reports whether the child had received WIC in the prior year. And this is just the difference in difference equation that we use, the beta one here. So this will be the estimate of the impact of DACA on uptake of WIC. And what we found here is, first of all, you can see our 2 groups are citizen children who have DACA ineligible mothers and those with DACA eligible mothers. The kids are similar in terms of age and gender breakdown, but as expected, the mothers of children who are not the mothers of children who are ineligible for DACA are older individuals who have been in the country a little bit more recently, so they haven't been in the country as long. And that's just a reflection of DACA eligibility criteria. And what we saw here, this is unadjusted, but it shows the percentage of children participating in WIC. And what you see here in blue are children who have mothers eligible for DACA, and gray are children with mothers who are ineligible for DACA, and red here is the dotted line shows years of reported, or that's exactly, sorry, when when DACA was implemented in 2012. So that's when the policy started. You can see prior to the time of DACA implementation, there is a trend that was actually seen nationally, an increase in WIC uptake up until during the recession, and then kind of a post recession decline. That decline continued in kids whose moms were ineligible for DACA, but in kids whose moms had DACA, that decline actually did not continue. So it kind of leveled off over time. So what that meant looked like, though, once we adjusted for multiple covariates, is we did find that children with DACA eligible mothers were more likely to participate in WIC following policy implementation. And this was compared to children whose mothers were not eligible for DACA, right? And on the order of 12.3 percentage points. So this was important in saying, hey, this is a policy lever, right? This is a way to help these vulnerable kids take up services that they aren't otherwise getting or accessing. And so it's an important way for us to promote the health of these vulnerable children. That's one thing. Another interesting thing that came out of this is that this was a amicus. I'm going to say these words like I know what they mean, but I really don't. It was an amicus brief that was filed by the Mexican government to the Supreme Court in support of DACA. And this was at a time during the prior administration, in which time there was a lot of concern over DACA being able to continue as a program. And it was a very long brief, but at one point they were able to highlight here the fact that DACA recipients, when they have the benefits on U.S. citizen children. So they talked about, they highlighted our study and also some other important work in this area. So there's a body of work really looking at these spillover impacts. And I think this just highlights the importance of adding when you have evidence of these spillover impacts, people care about kids, right? And you can advocate for policies that help their parents and that also help them. And it really just makes, I think, the advocacy for these important policies for vulnerable families richer. And so it was nice to see that we could have this type of inclusion in these, whatever an amicus brief is, but essentially to kind of advocate for this program. So I think that's why I highlight the advocacy piece of this. Wasn't expected, but we very much appreciated that, hey, this type of work can matter in other ways as well. And not just in informing the policy, but advocating for it. And related to that, there's one other example of this. So this is, I call this the story behind the tweet. So this was tweeted by the American Academy of Pediatrics. And this was in response to one of our research studies where we looked at parental health insurance and child health care receipt. And basically they say healthcare coverage benefits the whole family. So this is the American Academy of Pediatrics really promoting the ACA, which was for adults, right? So, but they went into that space and said it's important that the parents are covered, right, for health insurance. And you might think, okay, parental health insurance, what does that have to do with a kid getting health care, right? That seems kind of far-fetched. But this is where, again, I think it's important to think about the family unit as a household, the shared opportunities for healthcare and how families work, especially lower income families where a lot of the access and utilization are intertwined and resources are intertwined. So there's several ways in which others have also posited that this concept of a parent having health insurance helps a kid receive health care. It could be through what's known as a welcome mat effect, where a child gets health insurance, so their parent also when a parent gets health insurance, they also enroll their child in health insurance that they've already been eligible for. That having health insurance for the parent, and what has been shown with the ACA, improves the family's financial standing overall, so frees up resources for other family members to get care. And that if parents are utilizing healthcare for themselves, they may be more likely and more comfortable also utilizing it for their children. And so those are the potential mechanisms by which you could even see this connection, right? But you really have to think about the family and the generations to be able to say, hey, we might see this signal. We had looked this through, we also did a quasi-experimental study. I will just highlight that MEPS, which is another national survey, also lets you look at household members, so connects them. I won't go through the details, but I will say that the story behind the tweet is that we did find that for low-income children, the probability of all child visit receipt increases by 29% when a parent is enrolled in Medicaid. And so that's the story behind the tweet. And so it's not only the AAP, but I got reached out to by somebody from Michigan who was with a coalition that was really promoting child health, but wanted to be able to highlight this because they wanted to highlight that Medicaid expansion for adults can help kids, and it was just another way for them to advocate for that as well. So I put these out as like hopeful stories as we move forward with respect to the policy and advocacy fights that we will surely be having in the next several months and years. To just give another example, and I'm sure you all will have other ideas of how to look at this and other spillover impacts that we may not necessarily think of, when we look at a policy right away, but could potentially examine further. All right. I think I will actually ask Dr. Cruz and Cooper. So I know I'm at 4:10. This part is long. I can give the cliff notes, or if you'd like, I can pause here to see if there's also more comments and discussion.
What do you think? Maybe try the cliff notes and then
Okay.
yeah.
All right.
What do you think? Lisa, what do you think? Yeah, I mean,
I think that would be fine. I think this is just totally exciting work. It's just incredible, We could probably listen to you for hours. So, but anyway, we'll take the Cliff Notes version.
Okay.
Give us the cliff notes.
Oh, thank you so much. Okay. I can't listen to myself for that long, so thank you very much for that. I'm happy to, so let me give you the cliff notes here and I'll talk about diabetes prevention. I think in terms of the cliff notes, I'll just motivate what we are doing with the Family Diabetes Prevention Program, and I'll leave it there, and I'll leave you to hear about the results at another time. But here is, so here's my next health equity challenge, and Dr. Golden will, I'm sure, highlight this as a big one. So preventing type 2 diabetes is a public health challenge, but it is also a health equity priority. And I think you've all heard a lot about type 2 diabetes, but likely in adults. So we know that 38 million adults have type 2 diabetes in the United States. And unfortunately, groups that experience health disparities in other conditions also experience the highest burden of type 2 diabetes, so among racial and ethnic minorities and lower income populations, and also complications of the disease. Waiting in the wings, in addition to these 38 million adults, are around 90 million adults who have prediabetes, a condition which puts them at increased risk of developing type 2 diabetes over time. So there is high urgency to really see if we can prevent these individuals from developing diabetes. And indeed, we know that if you have prediabetes, there are things you can do. For example, losing at least 5% of your weight if you have the weight to lose, being more active, so that type of lifestyle change to help prevent or delay onset of type 2 diabetes. So we know that there's that this group is one to focus on. So you've heard a lot about adults, I'm sure, but what about kids? So this is the part that when I was looking more into it, actually really is upsetting to think about. Type 2 diabetes is also rapidly rising among youth. And the prevalence is actually projected to increase fourfold by 2060 if these incidence trends, which have been basically showing an increase in incidence over the past several years, continues. 80% of youths who have type 2 diabetes currently are individuals from racial and ethnic minority communities. That disparity will only get worse as this problem grows. And 40% of those kids live in low-income households. So the same disparities you see, right? Disparities across generations, there's no reason that they're stopped by any barrier across generations exists. And then furthermore, obesity, which is a major risk factor for type 2 diabetes, and you have heard others speak about it, like Dr. Perrin before, nearly 1 in 5 kids have obesity, and they're the same breakdowns in terms of disparities of obesity and overweight prevalence in children. So this is the public health and health equity challenge. Like, how do we really focus on youth? But I will say, so that's a challenge that hopefully we can address. I will say that we're doing it, as a country, though, we've really focused on adults, and that's also a great thing because that is an important challenge as well, right? And how we have focused on them in multiple ways, but one way you may have heard of, and that I think is a great program, is the National Diabetes Prevention Program Lifestyle Intervention. So this program, for those who are not as familiar, is a program that's actually supported by the Centers for Disease Control and Prevention. It is for adults who are at high risk for type 2 diabetes and also have at least overweight status, because the goals of the program are for them to lose 5% weight loss from baseline, and also achieve 150 minutes of physical activity a week. So it's a lifestyle intervention program that teaches them how to reach that goal. And how do you get to that goal? So it's a 12-month-long program. It's group-based. It is a CDC curriculum that's delivered, which covers various topics through the year that really empowers the individual to make changes to achieve these goals. And it's delivered by a certified lifestyle coach who can have any background. They just have to be trained to be the lifestyle coach. I actually underwent the training. I'm not a great lifestyle coach, but I underwent the training. And there's many ways that it's delivered. And I think one of the keys here is, and I've had the good fortune of being able to work with Dr. Maruther and the Brancati Center here in delivering the program. And I would say that as a coach, and as a primary care physician, it really it's like wonderful to see that there's a program out there that is accessible to my patients, that does what I can't do in the primary care clinic consistently, which is provide this type of lifestyle change and behavioral modification support, and that achieves these goals over time. I call it a 12-month hug because I really feel like that's what happens to participants over that time period. And it's a great program in terms of having the potential to address disparities, to advance equity, right? So it's about preventing diabetes, but it's also about reaching groups that experience the highest burden of type 2 diabetes over time. For example, the national DPP is covered by Medicare as one of the first preventive programs that receive this coverage, but also have Medicaid coverage in 29 states that have opted into providing some type of coverage through Medicaid. It's also a program that can be delivered in community-based settings by community-based organizations. You don't have to be a healthcare setting. And so this enhances the accessibility of the program for individuals as well. In addition to that, as I mentioned, I have had the good fortune of working with the Brancati Center team, who's delivered the program in Baltimore City since 2016. And the center started off and has continued to really deliver this program through strong community academic partnerships with community-based organizations in Baltimore City. The focus is really on reaching populations locally that experience disparities in diabetes. And so the center has been able to augment the program by adding community health workers to our team so that we are able to screen and address social determinants of health that may impede our participants' ability to make these lifestyle changes and maintain them. And also augment the curriculum. The existing curriculum, you have to use the CDC's curriculum, but you can augment it to a certain extent. And we have done things such as cooking classes, grocery store tours, offered opportunities for physical activity. So it's like a tighter hug of the 12-month-long hug that's possible, right? So it's just an exciting program. Again, it's like you really see how people move through this 12 months, form a sense of community with their group, and really are empowered to make lifestyle change. It's great. And so as an internist, it excites me to no end to see this for my patients. But as a pediatrician, I don't have something like this to send kids to in the city, not locally, and nor is there something that has this national scope. And so, and thinking about it, I think the bottom line is the Cliff Notes version is, I think we need to expand this program. And what we've been working on doing is create a family version of the program. And I will just say why would this program be good for kids as well? One, I already mentioned it's accessible to populations that experience diabetes-related disparities. The structure of the program also actually enables you to add sessions near the end. So it's a 12-month-long program. The first 6 months is really when the parents get, or the adults get, like the main information, and thereafter it's more of maintenance sessions to help them reinforce lessons. But those sessions meet less frequently, so you can have child-focused sessions then. And it also reaches high-risk children, so it should not be probably a surprise that kids whose parents are eligible for the DPP, as we show here, 1 in 3 of them themselves either had overweight or obese weight status, which is a major risk factor for these children for type 2 diabetes. And it has a potential for a greater impact on child lifestyle change because, one, the caregiver is already involved, and for child lifestyle change interventions, it's gold standard to involve parents. That's why they call it family-based treatment for obesity. and in this case, you already have a caregiver who is changing things for themselves, right? So that's great. And in doing that as well, the caregivers have actually described to us that they're already changing stuff at home for the kids. So I think the program as it stands probably has some benefit for the children. And this is something that we found, these are themes that came out of some in-depth interviews that we did of our Bronchitis Center DPP participants who are caregivers of kids, but they just described various ways in which, as being in the program, the DPP for themselves, they were seeing changes in their children and their household members. So clearly, as this mom describes here, there's already a spillover effect on the family of a program like this. And I think it could also be more impactful for adults because it could enhance motivation and engagement of younger adults who are harder to get into this program in general. But if you say you can, engage children, they may be more motivated to come. And also, it'll help us address any lifestyle change issues that adults may face trying to make these changes at home when kids could be a barrier to those changes because of their dietary preferences, et cetera. And so this is what we conceptualized that the Family Diabetes Prevention Program could do. And basically, just like the DPP, it works on knowledge, attitudes, and senses of self-efficacy, but also the household environment. And in the case of a family program, if you focus on teaching parents and kids parenting self-efficacy to not only help the adult, but also the children as well. And because it's a Cliff Notes version, I will just say that we've done this so far, and we've created the family DPP. We added child supplementary modules, and we did it with input from community members locally who had been through the DPP, just to confirm that the content was going to be helpful especially to families from the city. That is my focus, really, are the patients I take care of through my clinic as well. And this is the part where I'll leave you a cliffhanger, but we have conducted the pilot study, and I will, because of time, I won't go into it more, but in the pilot study, we essentially enrolled about 12 adult child dyads, and we were really looking at measures of feasibility, acceptability, and fidelity of program delivery, but also looked at some secondary impacts on child behaviors as well. But I will leave that for another time. So I'm just going to go through really quickly and just show Man's thank you slide to end here. So I just hope that through this today, through the case studies, hopefully you have seen how multi-generational approaches really enable us to make sure every person has the opportunity to achieve their full health potential, and also address those disadvantages that families have as a whole with respect to achieving their potential, their health potential in life. And with that, I just will end on this thank you slide. There's a lot of people on here. I'm missing a ton of people, but these are really my mentors and guides throughout the work that I've done here. And a special thank you to, of course, patients and families that I've cared for, our community partners at the Bronchitis Center, and a special note for a tribute to Drs. Hilbrigg and Dr. Levine, who really impactful, extraordinary scientists and human beings who I think moving forward as we do the hard work will really draw upon their legacy as we move forward with the work that we do. And with that, I will stop sharing.
Well, thank you so much. It's a really, really excellent talk, and we're, I think, excited and also grateful for the work that you're doing, because it's so important. I definitely want to open it up. I know we have a few minutes here. We want to open it up to see if folks have questions. I saw a couple of comments in the chat. I wanted to see if is it Asta Ramaya? I don't know if you wanted to make your comment verbally or ask a question if you.
Hi, I'm actually in the car, so which is why I typed it in the.
It's okay. We can hear you well, though. We can hear you.
Okay, fantastic. So this was such a fascinating presentation. Thank you for everything you're doing. So one of the things that I have is this notion of, when we think about multi-generational families, usually we think about like a nuclear family, which just has like a mother and a child and maybe a father, you know? But I know that within the US and also in global settings where I have been working, we have like people who extend outside that nuclear family and have extended family who have their own norms, you know? And so I think one of the things, and the reason I'm asking this is because I'm in the process of writing a grant that is thinking about what are these policies and then how are these norms at the institution level, but also at the family level, affecting service utilization for violence and specifically family violence, you know? And I want to take an inclusive approach to family without thinking about the nuclear family. But I also realized that that involves money, you know, and within the US and in other systems, it means that someone needs to do this extra work in order to meet the needs of the program and in order to streamline. So I was wondering, one, what your thoughts were about this this notion of norms and service utilization as well as policy, but also like where is this money and can we task shift, you know? And I know someone talked about community health workers, and I would love to hear more thoughts around that.
Thank you so much. And it's really exciting to hear about the work you're doing as well in the settings that you work in. I think to take the last part first, that's a great question where the money is. So this is actually, I think, independent of asking individuals to do more, and I know Dr. Ibe will agree with this, we aren't paying enough for what people are doing now. So that's probably where we have to start, right? And making really paying people, I mean, you know, reflecting their contributions and the worth of what they're doing and what they do, and how much they, you know, are paid. But I think with respect to thinking about task shifting, we can't do it. I think you're right. We just have to be careful that you're not adding on. And that's why the pediatric example was one where this tax shifting burden I was really thinking about from the provider standpoint, but it's clearly on the entire team. It's also on that medical assistant who has to take mom's blood pressure, right? When normally they're not taking a mother's blood pressure at the visit. So I think that that is, I don't know that there's an easy answer to that, except that if we do these things, I think the key is introducing auxiliary team members, right? But that's still more people, and that's more people you have to pay. So with respect to the funding aspect of it, it is a point of showing to the folks who control the funding what is the why this works and why is it impactful. And I think that can help, right? And sometimes there are different pockets of funding, and you actually, sometimes I think about the family DPP work. There's no program like this for kids, and Medicaid is not going to, hasn't ever covered something like this for kids, right? But the fact that it's being covered for adults, maybe you kind of like glom onto that and use that, you know, that funding stream and use that to eventually expand to other populations. So I think that's probably part of it, is you have to show people it's going to work and why it is value added for their funding mechanism or money. And then potentially, and if you're doing more, right, and it benefiting a greater population, then perhaps that will convince people to actually pay more for that type of work. I don't think I really answered that question, but then for the first part of it, though, I think with respect to the question of norms, I think one thing that I did not also highlight in the work here, I kept saying parents, but really when I mean caregivers, it's also true that in a lot of lower income households in the US, grandparents are a very important source of care. So 2 of our family DPP dyads were grandmothers, actually, who were in the program and enrolled their grandkid. And so clearly norms change across generations, and I think you have to be cognizant of that, but understand, I think the biggest thing is getting input from the people you're hoping to intervene on and serve about what they're willing to do, right? And what messages they need to hear, I think they need to hear, are the barriers that they see across all of those generations and household members in order to make your intervention truly reach everyone. That is the challenge of doing something that's going across age groups, is you have to do different things for each group, right? And clearly you're saying that for some other household member it may look different, but I think that's where getting the input in about what are the challenges you're going to see in these different generational models, and trying to make your interventions address those specifically can be helpful.
Thank you so very much. That was amazing. Thank you.
So good, maybe maybe in the last minute, there was
Mhm.
one question in the chat, and I see Dr. Ebay's hand up as well. But there was a question about whether there are any studies that have targeted health plans
Oh,
to sort of address this. I think this was
let me see.
Jessica Anguiano.
Oh, that's a great,
Is
okay,
pronouncing your
target.
name? I
Yeah,
think that
that's,
was.
okay. And is that, I guess this might be a question around like health insurance plans and coverage and see how they can promote this. To my
Mhm.
knowledge, I think a lot of this, well, for the primary care related work, I think a lot of the studies I've seen have honestly really focused upon just figuring out how to get a model out there that makes sense. And in so much as the plans themselves or the way thinking about like payers, et cetera, that challenge has come in the case of like dyadic care models and places that are trying to build new clinical models and understanding how to get that supported. So that's what I've seen there. I'm sure there might be others here who know more about that area. And I think that's mostly what I've seen is we're still kind of figuring out how to do it. And then the next step would be understanding who's gonna, how do we fund it or who will support those different aspects. I'm not sure if anyone else has more experience in that or can also weigh in, but
I don't think so, not in this space. I'm just learning the term dyadic care plans from you today, so.
I just learned it from my colleagues not too long ago.
Yes. Okay, Dr. Ebay, I saw you brought your hand down because I think you put your comment in the chat there, but
No, I put my hand down because of the time, so I'll have to ask Dr. Venkataramani later, but
I'll
just
just come to your
wanted
office.
yes.
No.
Well, very good. Well, for everyone, please join me again in thanking our speaker today, Dr. Venkataramani. Really, really appreciate it. We learned a lot. And hopefully for those that may have other questions and things for you, hopefully they'll be able to reach out to you. So
Yes.
thank you all.
Thank you.
Please join us again next month for our December jam session. So we'll be in touch. All right.
Thank you.
Bye, everybody. Thank
Take
you.
care. Bye-bye.
Bye.
Bye.